am thrilled that I'm going to get to introduce my friend and colleague, Dr. Ashley Whedon. Dr. Whedon is our medical weight loss specialist in pediatrics here. She has been heavily involved with the AAP and actually was one of the co-authors on the most recent guidelines. I think she's going to share some of that information with us. Ashley and I go back, we went to med school together, and then she did some training in Arkansas as well as some specialized obesity training with some of our friends down in San Francisco. And also additionally here in Oklahoma works specifically with the Chickasaw Nation for some of their clinical research as well. So I'll let you take this over.
Thanks for the introduction and for the invitation to be here. Let me make sure I can move this forward. Yeah. Okay. So, yeah, I'm happy to present on the, provide an overview of the new AAP clinical practice guideline. I have no financial disclosures to report. The learning objectives for today's presentation is to recognize obesity as a complex chronic disease, which I think, has been a theme over the last presentation too, to identify components of a comprehensive evaluation for obesity, as well as evaluation for the common comorbidities of obesity, to recognize evidence-based treatments for children and adolescents with obesity, and to identify resources to assist with the implementation of national guidelines. And I do have a disclosure that this content in this presentation is directly from the CPG and focuses on the recommendations for evaluation and treatment of obesity. So I am going to walk through the CPG. I want to acknowledge first that this is the first clinical practice guideline on obesity from the AAP. In the past, we've had consensus recommendations. So this has been a comprehensive process that occurred over the past 6 years during the pandemic. It's been longer than anticipated, but it began with a development of an evidence review committee, and we were tasked with reviewing the literature on 2 key questions. The first question was, what are effective clinic-based treatments for obesity? And the second question was, what are the comorbidities that occur with obesity? What evaluations do we need to be doing for children with obesity? So this was a significant task, as the last guidance provided by the AAP was back in 2007, and the field of pediatric obesity has evolved since then. The amount of new research that has occurred in the past 15 years contributes really the need for these new guidelines. So for this CPG, 16,000 abstracts were reviewed, a little over 1,600 full text articles were reviewed, and we drilled it down to about 382 studies that were reviewed and summarized and included into one of 2 technical reports. So the technical reports were on obesity intervention and obesity comorbidity. And that's when, going back, another committee, the Clinical Practice Guidelines Committee, began reviewing the data in the technical reports, grading the evidence, and then developing 13 key action statements and 11 consensus recommendations. And those topics included assessment and evaluation of obesity, comorbidities, and treatments. So one central theme throughout the CPG is that obesity is a complex disease. And while this is my only slide that's not from the AAP CPG, I include it because the CPG has a strong focus on multiple etiologies, or on etiologies at multiple levels, which affect a child's risk for obesity. So those include individual factors, family and home factors, including experiences such as adverse childhood experiences and trauma, and that's been alluded to in the previous talk, community factors, and societal influences. And it's notable that it's really the interaction between an individual's biology and the environmental factors that contribute to obesity, and we need to treat obesity as such. As a result, the CPG emphasizes the need for a whole child approach. Understanding all of the underlying factors for specific patients' excess weight gain is the foundation for evaluation and treatment. And while etiology is complex, what we saw was that multiple randomized control trials and comparative effectiveness studies showed that obesity treatment is indeed successful, or can be. A second core theme of the CPG is that obesity is a chronic disease. So this figure kind of depicts that. You can see the remitting and relapsing nature of obesity when they're engaging in treatment. So we have all the structural and contextual factors that influence treatment. And key parts of that are access to care and weight bias and stigma. That does influence treatment. If you know, a child and family is going to a pediatrician or a specialist and they're told, you know, to lose weight because of their choices, then that impacts weight bias, weight stigma, and they don't want to come back. So paying attention to all the factors, including the environment, adverse childhood experiences, and all the health inequities and social determinants of health leads to needing a longitudinal care coordination with children. And really the most important part is that this has to be shared decision-making with patients and families. So I'm going to move now right into the clinical evaluation recommendations and walk through the key action statements and consensus recommendations. Listed on this slide are the main areas that are covered in the evaluation section, beginning with measurement. So measurement of BMI continues to be recommended for screening and diagnosis of obesity as a proxy measure of underlying adiposity. Key action statement 1 says pediatricians and other pediatric healthcare providers should measure height and weight, calculate BMI, and assess BMI percentile using age and sex-specific CDC growth charts for all children 2 to 18 years of age to screen and diagnose for overweight, obesity, and severe obesity. Moving on to evaluation and assessment of risk, the recommendation and the technical report did not focus on, it focused on treatment and comorbidity. So that is why this is a recommendation, is to perform initial and longitudinal assessment of individual structural and contextual risk factors to be able to provide tailored treatment of the child or adolescent with overweight and obesity. And this is kind of a core concept, because if you don't recognize all those factors that I showed previously, then it's really hard to address and have conversations with the family about what factors are contributing for them and then how that impacts treatment. So as I already mentioned, the evaluation must look at the whole child and the context of the environment in which they live. So we need a whole picture. When we look at comorbidities, both of the technical reports showed compelling evidence that obesity increases the risk for comorbidities and that weight loss intervention improves comorbidities. Therefore, key action statement number 2 recommends that obesity and related comorbidities should be evaluated concurrently with an obesity-specific history and review of systems, family and social history, mental and behavioral health screening, social determinants of health evaluation, physical exam, and laboratory testing. So this evaluation provides pediatricians with an opportunity to assess both the etiology of obesity for that child, but as well as the complications of obesity. And recognizing that this does take time to do that is also in the guideline. The key action statements in the comorbidity section are limited to the comorbidities that were addressed in the technical reports. Those included type 2 diabetes and prediabetes, dyslipidemia, non-alcoholic fatty liver disease, and hypertension. So this slide describes the evidence to support the specific recommendations related to comorbidity assessment, because we had to go beyond the technical reports. The technical reports provided data on prevalence, age, and weight category associated with the comorbidity. So that was kind of the foundation. But really what we saw was the studies were limited on the optimal age for beginning evaluation and screening, the benefits and harms, as well as the type of test to use and the frequency of testing. So we leaned on clinical practice guidelines to help round out the recommendations here. So for that to be included, the guideline needed to be published in the last 15 years. The organization in our professional society had to be a leading scientific expert in the field, and they had to have had an established grading matrix to assess the evidence. So this key action statement encompasses kind of overall evaluation. This was a grade B for children with obesity that are 10 years and older. Pediatricians should evaluate for lipid abnormalities, abnormal glucose metabolism, and abnormal liver function in children with obesity, and also lipid abnormalities for children with overweight. So that's no real change. That's what we've been recommending for a while. Key action statement number 3.1 focused more on evaluation for those who have overweight in children 10 years and older, and that had abnormal, that were looking for abnormal glucose metabolism and liver function, and to do this with the presence of risk factors for type 2 diabetes and NAFLD. So it was a little bit more conservative, but it's also in line with the ADA and the NASH-BGAN guidelines. So obviously, y'all, this group is well aware of all the risk factors for type 2 diabetes, and then also for fatty liver disease, family history, central adiposity, insulin resistance, dyslipidemia, and sleep apnea. Now, this key action statement also talks about children less than 10 years of age, so in children 2 to 9 years of age with obesity. If the child has obesity, to go ahead and evaluate for lipid abnormalities. This was grade C. This whole key action statement was grade C instead of grade B like the previous one. But we did include the lower age limits on the children for evaluation for dyslipidemia, because in population-based studies, a lot of the younger children have high triglycerides and low HDL levels. So it was about 10% even in preschool age children, which led to this recommendation. For key action statement number 4, recommends concurrent treatment of overweight or obesity and the comorbidities. And that came from the technical report that there was substantial evidence to support concurrent treatment to achieve weight loss, avoid further weight gain, and improve obesity-related comorbidities. And this is also really key as far as working with families. So when you're talking about treatment, it is not just about weight, it's also about their health. And so multiple studies showed that cardiometabolic markers improve significantly in children with obesity. And it, again, provides that opportunity to emphasize health outcomes in addition to weight outcomes with management. So the next few slides are specific to evaluation of comorbidities, beginning with dyslipidemia. Key action statement 5 recommends obtaining a fasting lipid panel in children 10 years or older with overweight or obesity, and then may also, again, going back to the 2 through 9 year olds for children with obesity. And that's really in alignment with an NHLBI guideline, as well as the AHA 2018 guideline. For prediabetes and diabetes, for laboratory evaluation, it is looking at fasting glucose, an OGTT, or a hemoglobin A1C. This is what y'all already do. It's in alignment with the ADA recommendation, but it's also in alignment actually with the 2017, there was Peds Endo Society guideline for obesity. So in alignment with both of those. For a fatty liver, key action statement 7, it was to evaluate for that by using an ALT, and that was also based off the 2017 NASH-BGAN clinical practice guideline. For hypertension, pediatricians should evaluate for hypertension, measuring blood pressure at every visit, starting at 3 years of age with overweight and obesity at every visit. So that's different. I mean, I work with primary care physicians quite a bit. I go to their offices. We train them in their office. We do practice facilitation. We look at chart abstractions. We get pre-training, like even for just well childcare, when you know having blood pressures are missed on most of those preschool age children. So again, this is really to encourage frequent monitoring of blood pressure among children with overweight and obesity to foster earlier detection of elevated blood pressures. And it's also in alignment with the 2017 AAP hypertension guideline. So the CPG also created consensus recommendations on other conditions in order to cover the breadth of comorbidities associated with pediatric obesity. Earlier this afternoon, we heard about PCOS, obstructive sleep apnea, depression, idiopathic intracranial hypertension, and orthopedic comorbidities. So for those, a lot of those weren't included in the technical report. We included consensus recommendations for evaluation and initial management, and actually have a whole separate appendix to the CPG just on comorbidities for management. So frequency of testing, further evaluation, when to refer, those types of things. So now moving to treatment recommendations. So key action statement 9 is the overarching, summarizing key action statement about treatment. It includes the principles of chronic care model and emphasizes an informed family-based approach that acknowledges the biologic, social, and structural drivers of obesity in order to promote a non-stigmatizing approach, which is central to all treatment. This figure represents the core components of evaluation and treatment. The dashed circle represents the chronic disease and whole child approach by providing medical evaluation and monitoring, developing an individualized plan based on meeting the family where they're at. Some are ready for more intensive treatment than others. So it really is an ongoing discussion with families, tailoring the treatment to them, serving as a medical home, but also working with specialists and working with the community. On the right side here, these are in the yellow are all the different treatment modalities that are evidence-based tools to develop a tailored treatment plan for children and adolescents. So some of these tools can be used in primary care, but such as motivational interviewing, more difficult to implement intensive lifestyle treatment in primary care. And so working with a pediatric weight management specialist, working with specialists, working with community resources and community partners are critical there. So the first tool that I'm going to talk about is motivational interviewing. This is key action statement 10, that pediatricians should use motivational interviewing to engage patients and families in treating overweight and obesity. So MI's patient-centered counseling style that identifies and reinforces a patient's own motivation for change, in contrast to how we are trained to prescribe change. So MI guides families to identify the change that they want to do. And this is really critical because they have to have a voice in what's important to them, especially, there's cultural considerations. They have to have a voice in what's important. And they also are the expert in knowing what they can do or not do. And so for it to be able to implement, it has to be feasible. So that is why MI is recommended across the board, regardless of kind of what additional treatment that's done. But MI was also successful in primary care. So in the technical report, prospective studies showed that MI demonstrated a greater decline in BMI percentile and weight stabilization, especially in our younger children. And those were all low intensity treatments in the primary care office that were included for that. MI is also used in higher intensity levels as well, but this is kind of key because this can be done in primary care. The next key action statement addresses intensive health, behavior, and lifestyle treatment. So this key action statement talks about providing or referring children to intensive health and behavior lifestyle treatment. The dose of the health, behavior, and lifestyle treatment directly correlates with its effectiveness, with the most effective treatment including 26 hours or more over 3 to 12 months. So this is not new. We saw this with the 2007 USPSTF recommendations, but what is new is that we also use comparative effectiveness studies that provided even more data on the effectiveness of this type of intensive lifestyle treatment. And we also looked at kids in the preschool age and referring early at preschool age, they really had a significant impact on intensive lifestyle behavior treatment. So the earlier treatment, the better. This picture depicts the process of IHLBT, who it is. It's the patient and family with a multidisciplinary treatment team. Then now what's new in the guidelines is not a staged approach. It's referring or providing upon diagnosis. So don't wait and wait to refer. It is referring as soon as the diagnosis, if the family is able to participate in intensive lifestyle treatment, right? It's working with the family to see where they are at. It's health education, it's skill building classes, parenting classes, behavior modification. It can be done in individual clinic visits or in group visits. This can be done. Most of the studies were face-to-face, but there are some with virtual options that showed effectiveness. It's longitudinal. The at least 26 contact hours over 3 to 12 months. And most occurred in the healthcare setting, but we did have some in the community setting that had a linkage to a medical home. It requires significantly more time and resources than just a typical pediatric visit, which is why we have a whole team involved. The CPG talks about what to do when this isn't available, because access to care for intensive lifestyle treatment is limited. And so it's really talking about building collaborations with specialists or resources within their own community. If there's a dietitian in their own community, if there's a YMCA program in the community, working with them directly. And although in the TR, the intensive lifestyle treatment had the largest body of evidence, it's really important to consider the use of pharmacotherapy for children and adolescents who require an additional treatment option to manage their obesity. So Key Action Statement 12 gives guidance on that, recommending pediatricians should offer adolescents 12 years and older with obesity weight loss pharmacotherapy according to medication indication, risk, and benefits as an adjunct to health behavior and lifestyle treatment. For children younger than 12 years of age, there was insufficient evidence to provide a key action statement for use of pharmacotherapy for the sole indication of obesity, and so we have a consensus recommendation around that. It's important to note that no current evidence supports weight loss medication use as monotherapy. The pediatricians and other pediatric healthcare providers who prescribe weight loss medication to children should or provide or refer intensive behavioral interventions for patients and families as an adjunct to medication therapy. The final key action statement recommends that clinicians should offer referral for adolescents 13 years of age and older with severe obesity for evaluation for metabolic and bariatric surgery, to comprehensive pediatric metabolic and bariatric surgery centers. So this one's crucial that adolescents with severe obesity have access to that evaluation at least, and that the evaluation be done in a center providing comprehensive pediatric care, which was a key theme, and Dr. Fisher talked about that as well. The criteria for surgery per the new guidelines was class 2 obesity with a clinically significant disease, are now class 3 obesity, so BMI over 40 or 140th of the 95th percentile, not even having a comorbidity required with the new AAP guideline. So kind of takeaways here is that we have different levels of different treatment options, including motivational treatment, intensive lifestyle, pharmacotherapy, and surgery, and utilizing what works best for that patient. And we want to do treatment as soon as possible and as intensive as possible. So putting it all together, this figure here kind of represents kind of the crux of the CPG, in that we need ongoing assessment of all of in the evaluation of obesity of all the risk factors for that specific patient and to evaluate comorbidities, using MI and shared decision-making for ongoing behavioral counseling, and providing intensive lifestyle behavior treatment as available. It's really the foundation of care. But for some patients, pharmacotherapy and surgery are also treatment interventions that should be offered. Treatment should be individualized and tailored to the family and tap into the resources of those in the community, whether that's referring to pediatric obesity specialists, other specialists, or community resources as well. So the takeaways are that obesity is a complex chronic disease, that comprehensive whole child evaluations are important, that there are effective evidence-based strategies for treatment that are safe and effective, and that treating obesity also means treating comorbidities, and children with overweight and obesity should be offered treatment right upon diagnosis. The CPG recognizes the challenges for implementation of the recommendations, that there are multiple barriers. There's also multiple gaps and needs for future research, but there are obviously capacity limitations for a lot of these recommendations, and there are coverage issues. So there's a section of the CPG dedicated to advocacy on coverage for both lifestyle treatment, medications, and bariatric surgery. and templates to do that for each state as it differs because Medicaid differs coverage in each state. It's also recognizing for some of these more intensive treatment that families aren't able to participate in that and working with them to figure out to ramp up care for them and how to best meet their needs. And then there's a whole training, most pediatricians aren't trained in obesity medicine. And so working on developing trainings and skill to enhance skill sets of clinicians to have access to care so that they, to have for all treatment across the spectrum. So the AAP has focused on the Institute for Healthy Childhood Weight, has focused on developing implementation resources. This is their website. They have many implementation resources. They have CME modules. They have quality improvement opportunities. They have clinical decision support tools, coding information. They're working on a dashboard for EMR specifically for pediatric obesity. There's lots of family resources that have been updated. One of the key implementation is the new CPG algorithm. So this replaces our previous algorithms and includes all those key action statements for evaluation, for screening, diagnosis, evaluation, and treatment kind of in one place. And then in addition to that, there are essentially additional clinical flow for assessment and evaluation that provides more information, especially on all the comorbidities, and then treatment, what medications, what are the indications, what are the side effects, what are the contraindications. So there are a lot more tools that are coming out, and the AAP Institute for Healthy Childhood Weight, their staff, along with several of us on the CPG have been working on that so that that could be on the ground running when the CPG was released. I want to acknowledge all of the co-authors on the CPG, as well as the chair who their guidance led us through this process over the past 6 years, Dr. Sarah Hampel and Dr. Sandy Hassink, as well as the AAP staff for their support through this and for really their focus on all the implementation resources. I've given kind of an overview of all the key action statements and walking through, but the real work now begins with implementation of this and advocacy on developing resources more locally, not just in one or two places in the state. And so those conversations are already undergoing right now. And that's really with the help. There's a lot of policy moving. The AAP is helping to guide. They also have developed slide sets like these so that we can show, here are the key highlights coming from the CPG. I want to close with a quote from our family representative on the subcommittee, because I think he summarized it really well. It says it is his fervent hope and of every member of the subcommittee that these guidelines and the resources that accompany them will provide you with a more complete understanding of the issues, the factors, the needs of patients combating overweight and obesity, as well as successful treatment options to assist them in their battle. These guidelines and the resources that accompany them are not only for you, they are because of you and all that you do to care for each and every patient as if they were the most important one, because they are. The references are the CPG and the technical reports. Happy to take any questions.
Thank you very much. Ashley, do we have any?
Made up time.
Quick. Dr. Jeter, coming your way.
I love any reference to motivational interviewing.
Wait, where are you?
Okay, that's true. Hi. Okay, so one of the last few slides you showed motivational interviewing was one of the frontline foundations for overweight and obesity all the way across the way. How do we get our multidisciplinary teams to get more than a 1 hour intro to motivational interviewing? Because we know for motivational interviewing, the more exposure you have to it, the more likely you are to be doing it correctly. Yeah. And that for a lot of people, what you think is motivational interviewing really isn't. Yeah. So how do we get to that point?
So I think that's a really important comment. And I think that's not true just for motivational interviewing. I think it's a lot on the pharmacotherapy, and all of it is that the training most clinicians aren't trained in MI. Most clinicians aren't trained in, in medications and obesity medicine. And so that's why AAP right now is developing all these different modules so that they can have some specific training. The state is investing in trainings for motivational interviewing coming from this. So I'll be talking to you. And they are also investing, like OSU runs a pediatric echo that you can get on like every week. And so for the next year, they're going to focus on the CPG and how do you kind of utilize this in your practice and how can you implement it. Additionally, there are groups of us, we're trying to, obviously I'm one person, but what we're trying to do is we now have on the Oklahoma chapter of the AAP, we now have 4 obesity medicine specialists, and we are kind of tackling different parts of the state by trying to provide in-person trainings and provide the resources from the implementation on the AAP Healthy Institute childhood weight. Good question.
Coming. Okay, I'm on my way back to you. So, okay.
This is probably a repetitive question. I know this has happened over the years. Parents argue against BMIs.
Mm-hmm.
Oh, I'm big boned. Oh, they have a large muscle mass, and I am running out of ways to explain that this is still used as a standard. But I want to know that I want them to know that I hear them and that everybody is shaped a little differently.
Yeah. So really important, especially right now, because there's a huge BMI cancel culture right now going on. There are actually groups, national groups that have formed to say, I can't remember the exact website, but it's my body, my size, my acceptance, those types of, which are, that is important. And we have received huge pushback on the CPG related to concerns that we are focusing on BMI, because then we're focusing on, we're going to create a bunch of eating disorders. And actually we looked at that. And what happens is if you have a conversation with a family and so the focus isn't on BMI, right? So what we know is what you can share with families is when your child is above this percentile, 95th percentile, we have studies that show that correlates to for continued trajectory on this for excess weight gain. And I typically use excess weight gain the first time I'm meeting with the family, because I haven't, obesity is a disease and we talk about it, but like I'm developing my rapport with them. So I use the growth curve to do that. Then we talk about all the increased risk of all of the comorbidities and the cardiometabolic factors. I use family history there a lot, because a parent may not want to talk about their weight, but they will talk about diabetes, sleep apnea, heart disease in the family, those types of things. And, 9 out of 10 parents, right, they don't want those things for their kids. They may not see obesity as a big deal because, again, right now it's on the focus in our culture. We have to have a cultural shift to where this is a disease and not, a personal failing or a parent failing. And so it's having that conversation that when they're above this place on the growth curve, that there's increased risk for continued weight gain, but more importantly, there's the impact on health. And so I change it all to health and the focus on health. And that's why those evaluations are important. So of the kids that are referred to me, I have several come that say there are no comorbidities. And by the time I finish, and my evaluation is always a full hour, that I have at least got five. So one of them could be, for example, and the parent doesn't even know this, the child will talk about it. I can't keep up in PE, or my feet hurt after walking. My mom's trying to get me to walk every day, but my feet start working. Well, they have flat feet, right, from excess weight. And so that impacts them, and they want to be able to keep up with their friends. And so we talk about what's important to that child and what's important. And then the parent kind of buys into, oh, maybe there is something that's, excess weight's impacting them. And then we work from there. Does that?
Definitely. I try to disregard, like mention BMI, but really not focus on it. But I just had so many parents shut off when you even show them the chart.
Because they've already heard it. And so they're already in defense mode. And so I think it's bringing, well, what's important? Do you have any concerns about their health? It's reflecting back to them so that they can engage, because they're turned off because of a previous experience. I guess I talk with my hands too much. Anyway, so thank you.
Hey, thanks for the talk. Real quick, do you know if the AAP or sort of official organizations are putting together a response to the unfair and sort of scathing New York Times opinion piece? I think it was January 26th.
Yes.
Is there one in the works?
Yes, we've had like weekly calls. So there are eating disorders have also had one. Psychologists have had. We've gotten. I mean, this is a cultural shift, right? I mean, obesity, as mentioned in the Dr. Fisher, obesity as a disease was there in 1998, but essentially the AAP is outlining, like, here are all, this really is, an interaction between biology and environment. And here's why we need to focus on this now and intervene early and intervene more. So yes, they are working on, they have released some of those. There's actually on that website I showed you, there's multimedia presentations. So I've had to send those to the state health department because I got called pretty quickly about what are you doing? And so I refer them and send them to those responses.